All right, welcome everybody, and good evening to the Cervical Spine Research Society webinar on everybody's favorite topic, complications. As one of my mentors told me when I first started, if you're not having complications, either you're not operating enough or you're lying. And so here we are discussing all of our favorite cervical complications. We have a fantastic lineup of speakers today, including leading spine surgeons as well as a colleague from ENT as well. And we all want to hear that perspective as well with regards to some of these complications. Really honored to join you here with my co-moderator, Dr. Lee Tan. And I want to remind everybody that the official journal for the CSRS is CSS, Clinical Spine Surgery. There is an expedited review process for papers focusing on the cervical spine. For anybody that has papers that they want to submit, definitely keep CSS in mind, and we'll try to get the paper expedited, especially if it's a cervical paper. And then for those with social media and social media accounts, all right, I'm going to pass it over to my co-moderator here, Dr. Tan.
All right, thanks, Elias. I just want to take a brief moment to thank Maria and Allison, who put a lot of work into, putting the webinar series together. And one nice thing about this is that, everything is recorded. So it's great that, all the attendees today can watch it. But if you really like the topic, you can go back and watch it if you missed something, someone said. And also, please let your friends know that this is be archived and it'll be on available on YouTube for your reference anytime. So I think that's a really nice thing to have and have the authorities and experts to talk about a particular topic to help us getting better at our craft basically. Okay, so here, again, three presentations. So, Dr. Fontes will go first, and then Dr. Bobby Tay, and then followed by Dr. Stephen Chen. And then at last, we'll have some more Q&A. Okay, so, it's really an honor and privilege for me to introduce Dr. Fontes, who is a close friend of mine and also someone who I would call when I get in trouble with a complex case. And he's probably one of the most overtrained neurosurgeons. Did a full residency in Brazil and the full residency here. Two fellowships, one with Vince Trinalis, one with Chris Shaffrey, and now he's the program director at Rush, which is a very busy spine program. So I'm really honored, and it's a privilege to have him to give us his take on C5 palsy. So please, Ricardo.
Thank you, Lee. Thank you, Dr.
Good evening.
Aleem.
My name is Ricardo
There you go.
Fontes. I am Associate Professor of Neurosurgery at Rush University Medical Center. I'm also its Residency Program Director. And it is an honor and a pleasure to be here with you tonight or today or whenever you're watching this webinar on the CSRS series, this time complication avoidance and management in cervical spine surgery. I'm not sure I can talk about avoidance. I can definitely talk about management of complications. So I'd like to thank the CSRS, Dr. Lee Tan, for this invitation. So these are my disclosures. They're not applicable, I think, to the topic of this conversation. And I'd start by saying there's this, you'll never forget your first C5 palsy, and that rings very interestingly to Brazilian ears. Those who are in their 30s and 40s will remember there was this vintage ad on Brazilian TV of a teen clothing line that used to say the first one is unforgettable. And by chance, the actress turned out to become really famous later on. And so this is a common expression in Brazil. The first one is unforgettable. And I certainly cannot forget my first C5 palsy. And here's the case. It was a 3-level ACDF, one of my first cases as an attending. And that's usually when it hits you, right? When you're getting started in your career, everything goes really well. And all of a sudden, a patient has this terrible deficit that really affects their quality of life. And the interesting thing here in this case, I've saved the X-ray to this date. When I came here to the U.S. for my fellowship, I was really humbled by Dr. Vince Trinell, my fellowship mentor, and I realized I didn't know how to do an ACDF as well as I thought I knew. But I look back on this radiograph and I think about how much, grief I had regarding this case and how much I worried. And ultimately, he made a full recovery, though he never returned to his preoperative function or labor. As much as I looked at this radiograph, I said, you know what, this radiograph actually looks pretty good, even today. So I think all of us who do cervical spine surgery will face this at some point, right? And I think this is common to spine surgeons anywhere in the world. And if there's any consolation for you who may be watching this, who are facing a similar problem like I did almost 20 years ago, I can tell you I've had multiple C5 pulses. I've had C6, C7. I've had bilateral C5 palsy, which was terrible. I've had delayed C5 palsy, which I could not believe when I first saw. And most patients, like the literature says, like normal neurosurgical teaching goes, but go on to make a full recovery. So don't despair. I've had patients who had partial recoveries, but still were pretty functional. And so don't despair. This will happen. And I hope some of what we present today may help you in dealing with this complication. So most of what I'm going to talk about just came out recently as another one of Vince's phenomenal papers, right? I think Lee and I and our friends who are co-authors on this paper will promptly acknowledge we were there for the ride. This is Vince's work. And he was really bothered by the lack of data, good quality data out there to discuss C5 palsy. So we tried to add a little bit more to the literature, and I hope that you'll find this helpful. So this has been recognized as the most common nerve deficit following cervical spine surgery, almost as early as cervical spine surgery became popular. And the first report is now over 50 years old by Scoville. You have your the screenshot of the original description. And like most surgeons initially, Scoville blamed himself, called it a cord contusion. The patient went on to make a full recovery of the C5 palsy proper. It's known to affect a significant portion of surgeries. As usual in our specialty, you'll find people who say, I've never had this complication. But most people report is anywhere from 0 to 30% of surgeries. It's widely known that posterior surgery is more affected than anterior surgery, and that may impact our understanding and our explanation of this problem. And it usually presents very early, either immediate in the first few days after the surgery. And what will become evident to you as soon as you have one is that it negatively affects the quality of life to a significant extent. The clinical presentation is that of a predominantly motor postoperative nerve deficit. There are some reports that show predominance of a painless presentation. Others report sort of a prodromal presentation with pain over the deltoid area and the C5 distribution. But almost universally, very consistent in the literature that there is sensory preservation. It's more common in the early days after surgery, but may impact surgeries even out to 3 to 4 weeks after the surgery. The classical teaching is that of a presentation with impairment of shoulder abduction. Now, that may not be the best way to evaluate a patient for C5 palsy. In fact, we know that shoulder abduction is a compound movement, classically described as having one agonist muscle, the supraspinatus, for the first 15 degrees, which is innervated by the suprascapular nerve, which has a significant proportion of C5 fibers. Then from 15 to 90 degrees, the main effector would be the deltoid, which is innervated by the axillary nerve. And then above 90 degrees, you have the serratus and the trapezius, which get innervation from other fibers. But the reality is, it's not so clean cut in kinesiology, right? I mean, you have some agonist action of these non-C5 innervated muscles throughout the whole process, throughout the whole range of motion. So the clinical presentation when we test a patient with a typical chicken wing type of abduction is that the patient can still do the first 15 degrees, and then it gets and then the patient can't elevate, so it's normally rated as 2 out of 5. What's most sensitive for C5 palsy is actually external rotation of the shoulder, which is affected by muscles that are purely C5 innervated or predominantly C5 innervated, and also may be impaired to some degree the internal rotation of the shoulder, although it has a much higher proportion of non-C5 innervated muscles affecting that movement. The proposed etiology, the initial proposed etiology, was direct mechanical injury. To this day, we don't really know what causes, and in fact, medicine very, very seldom gives us the luxury of a true explanation of things, right? Especially in spine surgery. But direct mechanical injury has been proposed based on the fact that patients go to surgery, wake up with a deficit, or very early with a deficit, so must be the surgeon, must be the Kerrison, must be the curette, must be the drill. But later on, even cases that did not involve direct manipulation of the C5 root start presenting with deficits. And so people came up with what we can group as indirect mechanical injury as the etiology. So foraminal stenosis to some degree is present. There may or may not be cord shift, but there's still an irritation of the nerve root. And we base that off the fact that it's motor predominant, the anterior rootlets are more at risk. It's frequently at the apex of the decompression. So if there's going to be cord shift, as in this case, it makes sense that it would be predominantly motor, and there is an association with correctional kyphosis that would lead to cord shift. So I would say indirect mechanical injury, a combination of these factors, is the most accepted mechanism today. And other things that have come up throughout the years, such as anterior horn dysfunction due to an association with T2 signal change, spinal cord ischemia, or reperfusion. These have sort of fallen behind, though you may still find them. The results of our work, when we looked at the issue, we realized the literature is full of case series with or without univariate analysis. There weren't really any multivariate analysis of these factors in combination. So we did initial expert review, identified the factors that not only we thought was important, but there was also some data to study, reviewed everything out there on PubMed, and then once we collected the data, we tried to do a meta-analysis of the results when possible. And ultimately, we focused on 5 different factors. So preoperative foraminal diameter at C4-5, cord shift to C4-5, the AP diameter of the foramen at 4-5, cord rotation, and change in the C2-7 angle, and the lordosis. The overall data we compiled showed an incidence that's in line with what's out there, so anywhere from 4% to 24%, depending on the approach. Posterior was more common. And the factor that came up with the most evidence to support it was foraminal diameter. So the odds of C5 palsy on our analysis tripled for every millimeter decrease in foraminal diameter. Similarly, and perhaps most importantly, the AP diameter also had a strong correlation independently with the odds of C5 palsy doubling for each millimeter decrease in foraminal diameter. There is enough data to also establish a relationship to an increase in lordosis. So 1.7 times higher odds of C5 palsy for each degree of postoperative increase in lordosis. This is important because you can increase in terms of units of measurement, you can increase lordosis much more, right? So when you're talking foraminal diameter, you're frequently talking about a decrease of 3 to 4 millimeters in the foraminal diameter. Here you can increase the lordosis by 10 degrees, 15 degrees, and that should play into your surgical strategy. And then other things, there's simply not much out there. So cord shift, the data was inconclusive. The papers that really showed an association weren't very, very good. And they weren't really adjusted for foraminal diameter. And so foraminal diameter is really what stuck out. And preoperative cord rotation is a novel thing, but there was just not any data out there to analyze. Other factors that we came across, but we couldn't really establish, were foraminal cross-sectional area, the cross-sectional area of the nerve on ultrasound, and the intervertebral disc height. These factors remain to be studied. As far as what to do with C5 palsy, again, the thing that's still to this day the most important is counseling. With 5 seconds that you spend counseling can preoperatively can avoid 5 hours of explaining them postoperatively, right? So that's something I talk to every patient with with cervical spine surgery, not necessarily at 4-5, especially posterior. It's something that must be brought up in the planning, in the discussion preoperatively. As far as surgical planning, we know there's increased incidence in posterior approaches. So you need to count to take this into consideration if there's foraminal stenosis. So either treat it anteriorly, treat through a combined fashion, or do a full foraminotomy. The data on prophylactic foraminotomies, or so-called prophylactic foraminal decompression, is controversial. That's because the paper that has most cases, like Nakashima, actually showed that the C5 palsy rate increased, and there were so many confounding factors we couldn't really establish anything there in our review. Patient cases were not controlled for stenosis. You didn't know if you were treating the stenosis or if you're doing prophylactic. The fact is, if you're going to do prophylactic, do a full foraminotomy. There was a concern over eventually removing the fixation points for the lateral mass. They'll just open the whole thing. Don't do any wimpy foraminotomies. And then you may also limit your correction if you're doing posterior only. Regarding the EMG, that's something that comes up very, very frequently. I did it, free running EMGs during my cervical case for about 5 years. It's absolutely random. Too many false positives, too many false negatives, and the MEPs were just not sensitive enough for a pure C5 pulse. I mean, the MEP is really a cord monitoring technique, so monitoring will not help you there. It's not going to be reliable. That's the gist of the data. You may love it or may hate it, but the gist is that it's not. I do monitoring most cervical cases I do, and it's not useful to prevent or early detect C5 palsy. Steroids, you may do it if you want to. No data out there. I think postoperative imaging is warranted, at least the CT, to make sure the position of your implants is good. You may elect to finish decompressing the foramen. If there is foraminal stenosis, to do that, you'll probably really need an MRI. This is a case I did with Lee as my chief resident, and we had this terrible bilateral palsy involving multiple roots later, starting on day 5, really, on the day that had multiple roots. And to this day, I can't understand. But, these patients should engage in very early rehabilitation. And then let's not forget, about 15 years ago, we had the description of SOMSAX transfer. So that's something that really changed reinnervation procedures for these patients. So it's something that not difficult to do. So if you don't have a friend of yours who's a brachioplexus surgeon, learn how to do it yourself. It's not complicated. It's not morbid at all. And if by 3 months patients are not showing some sign of improvement, I'll get them an EMG. We'll repeat it at 5 months. And if there's no improvement, then we'll offer this. The problem with this transfer is that it's a radial to axillary transfer. You can consider combining it with an accessory to suprascapular, but that's an end-to-end transfer. So once you do it, you're going to section the axillary nerve, and it'll basically all sort of spontaneous recovery will finish it. So you have to establish this patient is not having any spontaneous recovery. So this is my first transfer. You can see the radial nerve isolated. You can see the axillary branches isolated, and there's a transfer. It's not morbid at all, and any recovery these patients get will be very happy. That being said, that is an exceptional procedure because most patients will show some degree of improvement by 3 months, and then they'll go on to improve until 18 months, 24 months. So as conclusion, I would like to remember this is the most common C5 nerve deficit following cervical spine surgery. You will have it, I guarantee you, unless you only do lumbar surgery. The stenosis, the foraminal stenosis, needs to be recognized and addressed in order to prevent. Every patient should be counseled regarding this complication. And again, have a peripheral nerve surgeon who's your friend, or learn the transfer yourself, because the results are very good if this doesn't improve spontaneously. Thank you very much.
All right. Yeah. Thanks, Ricardo, for a fantastic talk. A lot of information and helpful tips how to manage it. I think while we're waiting to see if any audience has any questions, my question for you, Ricardo, is that, does it influence how you approach the patient? For example, if someone has pretty significant foraminal stenosis, both in the AP or craniocaudal dimension, and you don't think that you can get a complete foraminotomy from the back, especially if there's, onset hypertrophy from the front, would you offer them anterior or combined approach due to the concern C5 palsy from posterior only? Or what's your thought process? Because, as you showed in the literature, the posterior laminectomy infusion tends to have the highest, posterior only tends to have the highest incidence of the C5 palsy.
No, it really has, Lee. I think I pay a lot more attention now to the foraminal stenosis. I think I'm much more aware of it. We tend to look at the cord a lot. I tend to examine my patients better because a lot of these patients will have preoperative weakness of external shoulder rotation, and which is just not captured. I mean, sometimes patients are very muscular. They can compound the shoulder abduction with other muscles. And so I always started testing for external shoulder rotation, started documenting C5 palsy, and I started including it in my plan. And it may be, it has become one of two things. Either I do a full foraminotomy all the way out the frame and posteriorly, or I will on occasion offer them a combined approach. Offer, for example, an anterior decompression, where I will force an anterior decompression to be able to decompress it better. And the anterior decompression offers you the ability to distract and increase craniocaudal height of the foramen. I have a question for you. Are you using shims posteriorly to improve height? I don't know if that's something you use or anybody in the
Yeah.
panel, if they use shims posteriorly.
Yeah. Personally, I have not. I have used it occasionally for to increase the fusion rate, whatnot, especially at the cervical thoracic junction. I haven't routinely used it to increase the foraminal height. I typically would go anteriorly and put the grafting and with onsenectomy to completely decompress the foramen. I don't know if any other panelists here use shims. But there are two questions from the audience, Ricardo.
Sure.
One is that is the risk higher with lami fusion versus lemoplasty? And the second one is do you get the foraminal CT recon on all patients?
Yeah, those are great questions. The risk is reported to be lower with laminoplasty, and I think especially after the so laminoplasties are procedures we did a lot in Brazil because of the cost associated. It was much cheaper to do, so the system really I had an idea they were super painful procedures, and I started revisiting them again. And in the last 5 years, I've dramatically increased the number of laminoplasties I do because I'm concerned with kyphosis. I'm concerned about C5 palsy, and the rate is lower. I will on occasion do a foraminotomy, about 50% of the foramen with a laminoplasty.
Yeah.
But I think when I see foraminal stenosis, I'm really concerned about it. The patient has some C5 deficit. I may offer an ACDF to perform the onsenectomy.
Okay.
And the second question, what was it again?
It's whether you get the CT for a foraminal CT for all patients.
Yeah, our radiologists hate that for some reason.
Yeah.
The Northwestern folks, like I've sent patients to Northwestern to get an oblique MRI, so to do a special reconstruction of the foramen.
Okay. For the interest of time, we can move on. But also just mention oblique X-rays actually helps really well to look at the bony foraminal dimension. So just ask your X-ray tech to get an oblique X-ray. That's also very helpful.
And I think the key things here are really sort of not putting your head in the sand with complications, right? So recognizing complication, sort of prompt recognition, prompt treatment, and really like recruit the help of colleagues, whether they're other spine surgeons, that are willing to come in, when you have a bad injury or anything like that, or even something you're not really sure about, like just it's always helpful to have another set of hands in there. And then of course other colleagues, and take a multidisciplinary approach, and then sort of getting the patient what they need. So thank you very much. Appreciate everybody joining us.